Brought to you by Sonda, Active Care Matters is a series where we bring you opinions, guidance and advice on wellbeing and safety in the workplace. Active Care is all about people being in control of their own wellbeing, their own safety and their own health outcomes, able to actively seek support on their terms, on their schedule and on their device. For organisations, it means proactively enabling and empowering people to get the care they need, where and how they need it, so they are more engaged and productive at work. Hello and welcome to Active Care Matters. I'm Craig Cowdrey, co-founder and CEO at Sonda. Today we are delighted to be joined by Professor Tim Shaw, who's going to be sharing his insights from extensive research into the innovative use of technology in healthcare. Tim is a leader in the field of digital health, an impressive history of cultivating innovative solutions for the healthcare industry. As a professor of digital health at the University of Sydney, he has been instrumental in driving research initiatives and building partnerships that promote evidence-based healthcare models. His accomplishments over the last 5 years have been really remarkable. He's served as a chief investigator on more than 30 high-impact and development projects, totaling over $124 million. Tim's commitment to transforming care through data-driven technology is truly remarkable. Tim will highlight some of his recent research projects, including the Practice Analytics Program. We'll talk a little bit about post-health, event management, and really focus on disruptive technologies and how they are impacting the world of health and even into the Indigenous communities and remote communities in Australia. So, Tim, thanks for joining us.
Thanks, Craig. It's a pleasure.
So to kick us off, I do like to ask about self-care for our guests, especially during COVID, but even outside of COVID and since then, you clearly have a lot on your plate. I've mentioned just a couple of the things that you're involved in. Can you give our audience some tips on how you approach caring for yourself?
Look, thanks, Craig. Probably not as well as I could do, like most people, I think. But look, I mean, it's pretty simple for me. And I often share that I do actually have congenital heart disease and a number of chronic diseases, so I have to kind of watch that a little bit. But look, I think for me, it's fundamentally about doing exercise and eating healthy diet. I think is at the heart of so much of what we do. And I do wrap a bit of technology around that. I did get an Apple Watch not so long ago, and certainly use the step tracker just to try and keep me going on exercise with that. But it's so simple, just trying to live well, exercise every day, and I think I've been playing with how technology does or doesn't support that. And I personally find the motivation of the step tracker probably the most influential for me.
Any tips on technology and how it can actually, can degrade some health in some respects? I know for me at home, I've been trying to keep the mobile phone outside the bedroom. So it's certainly, if it's in there, then to keep it on silent, no disturbs, settings. Anything there?
Oh, absolutely. I mean, I've got two kids, teenagers or 20-year-olds, and a 17-year-old. And look, I mean, I think obviously technology is a double-sided thing. You want to be, but again, I think you want to be out there doing exercise, getting out there doing things is most important. If technology supports that, it's great. If it doesn't, then it's not doing a good job, right? So I think it's about how we balance that.
Absolutely. And so you're a professor of eHealth at University of Sydney. Can you share with us the definition in your world of what eHealth is?
Yes, it's hard, right? And it's changed a lot. I began as professor of digital health at University of Sydney probably about 5 to 7 years ago now. Done a lot of technology before that, and we've seen an explosion in what we call digital health. So I think traditionally people tend to think of digital health in healthcare about electronic medical records is probably the most obvious thing. And I often actually argue that healthcare is actually high tech, low digital. And I think there's a lot of confusion around that. So, but certainly digital obviously means electronic records. How do we do that? With the COVID interaction, we've obviously had a massive acceleration in what people now often call virtual care. Telehealth, sometimes it's confusing, often included or not included in virtual care, but certainly in terms of how we can interact with health professionals in a way which isn't face-to-face. I guess I think what I've seen, though, was prior to COVID, that really largely revolved around geography, isolation. Post-COVID, it's much more now about convenience and how we can actually, it doesn't matter whether you're in Redfern or in Broken Hill, it's actually how you interact with your health professional through technology through that. So I think it's virtual care, electronic medical records, two of the big spaces in digital. Obviously, AI's on the horizon now, which I think lays into this again in terms of how we start to look at what we do with the large data sets that are flowing around us and how we can start to use that for predictive analytics and so on.
So high tech in the world of healthcare traditionally, R&D, high-end technologies and approaches to assisting people with health. But now this evolution of the digital healthcare revolution, really driven by COVID and really, from what it sounds like, driving that more consumer-centric approach to delivery of different healthcare services. And how have you seen that through the pandemic, but now outside of it? And are we going to maintain some of these adopted approaches, or are we going to go back to the old world?
Yeah, look, I mean, I think we've got to be careful because obviously I think the technology is the least important part of this, actually. It's the cultural change and the redesign and all these kind of things that come with changing the way we do things. I mean, really what happened in COVID was a flip from synchronous face-to-face to asynchronous, largely telephone calls. Right? It was not a revolution in many respects, but for me, it really opened the door to thinking how we can do things differently, and looking at different ways to wrap technology around a health consumer or patient to do care in a different way, having different people deliver that care. We haven't got there yet. I think it's opened the door to us to explore that, and we're starting to see elements of that being introduced into how we deliver care. But there is definitely a cooling, I think, at the moment in terms of that initial real enthusiasm for everything digital during COVID. And now, inevitably, with an innovation curve, you kind of come down the other side.
What's driving that? Is it regulations? Is it just a sort of traditionalist approach? Different interests?
I think there's a number of things. In COVID, we got rid of red tape. You could just do stuff. If you want to stand it up, you stood it up. We had to stand up whole health services. I work a lot with RPA, Royal Prince Alfred Virtual Hospital, and they kind of stood stuff up overnight, things that would have taken years to stand up. So I think there was that innovation. There was a willingness to try things during there. It was doctors and nurses and allied health professionals said, well, we've got to do this. Let's give it a go. So I think there was a real willingness. Red tape disappeared. We realized that we had to redesign things during COVID. So we just did it.
So now that we've got a bit of a breath and a moment to pause and reflect, how do we balance the potentially at odds requirements around sort of massive transformation, but also making sure that we are doing so safely and deliberately and sort of managing risks, especially, of course, in healthcare?
It's one of the biggest challenges I see is how do we change the conversation from telehealth to redesigning care or reimagining healthcare. And we were beginning this journey before, but I think the great danger at the moment is that we'll just go back to the way we were with a little bit of technology on the side. That you can maybe have your GP consultation via a phone call rather than by face-to-face, rather than actually thinking about how we redesign that care model around each individual. And it's hard when you're in a disruption cycle, which healthcare isn't a disruption cycle. It's happened to lots of other industries. How do you do this? Is it by kind of revolution or evolution, as we often say? I mean, other industries, obviously travel and banking and finance were fairly revolutionary in terms of the shift. Healthcare is slightly different, I think, and so we've got to look for ways that we can start to clearly demonstrate that doing things in a different way, doesn't decrease outcomes and care, doesn't degrade the experience, and also does that in a way that's cost effective. So I think we've got to start to demonstrate that. But I think we do need to move beyond just pilots to look for some really different ways of actually delivering that care into the system. And there's beginnings of that out there. There's elements of new programs where we're saying let's redesign models of care around total populations and so on. But we've got to have some bravery as well within the system to take some of this on, to actually explore this redesigned care, and then just always doing the R&D and the evaluation alongside it to make sure that we're doing it in a safe and effective way.
And healthcare has a commercial element, of course. It requires a business model, transformational disruption, I'd imagine, to go along with some of these changes if we want to have a more consumer-centric, personalised approach. Would you agree?
Totally. I mean, anybody that works in healthcare without realizing it's a business is going to run aground at some point. And look, I think the other big thing that's happened is there's a lot more players moving in here now. There's a lot more businesses starting to move in. We've had some very major players over many years looking at how they can interact with healthcare. But I think something that COVID's done is really push those businesses in so that people are saying, hey, we can do this differently. Healthcare has often been quite isolated and not really engaging with external businesses other than in a very transactional way to buy a service rather than actually have different providers coming in and doing healthcare in a different way. So I think that's the other real challenge for traditional healthcare is we've got these disruptors.
And at the moment, you have a number of players, without naming any of them, who are providing sort of online scripts, asynchronous care and consultations. You've got GP groups who are resistant to some of that. You've got pharmaceutical players also being involved in this, pharmacists primarily as part of that group. How do you see that playing out?
So again, I think we have to be very careful in how we move through this process. So I think the worst thing we can do is shut all this down, right, and pretend it's not happening. I think we need to work with the disruptors and the innovators to understand how we can integrate new approaches into the existing models of care and the way we deliver care. We don't want to create two universes here. I think we want to try and create one single system, and we have to move slowly through that together. So a lot of my research is working with industry, is working with the disruptors, saying, if you identify somebody in a community with very high blood pressure, okay, identifying them is great, but what do you do about it then? How do you support them as an individual, but then how do you perhaps make sure that they get tracked into a more traditional healthcare pathway?
And here at Sonda, I mean, we certainly pride ourselves on striving to deliver a really personalised, proactive, consumer-centric, but human-centric, not just about symptoms either, solution and support for people. And we're really excited about what the future holds on that front. But it certainly is going to take a continued commitment to really help drive these things through. But I wanted to ask you about delivery of support in that manner into remote communities. Now, you spoke about whether it's in Redfern or Broken Hill. I know you're also doing some work up north into remote communities, Indigenous communities. Love to hear about what you're doing there and what you're seeing is really required to help tackle some of the really challenging problems that we see in that part of the country.
Can I come back to that and just make a comment on your personal, sure. How do we do this differently and what are the disruptors bringing to this place? I think that the really big shift that has to occur is to make care about the individual. It's about personalising that healthcare to the individual. And I don't think anybody, we have some of the best healthcare outcomes in the world. There's no doubt about that. We have very dedicated, excellent healthcare professionals, but I don't think anybody can say the way we deliver care at the moment is personalised to that individual, right? Or is actually consumer-centric. It's still largely built around the healthcare provider themselves and us fitting with that. So I mentioned earlier, I have cardiovascular disease myself, and nothing has changed in my care since I was 10. I still see a doctor once a year. So all that stuff just happens as the way it happens. None of it is changing it and saying, how does it fit differently for Tim, and how do we make that actually happen? And I think that's where the disruptors are coming in. Often they work really well with individuals. They work with consumers in a really proactive way and lots of other ways that they do business. And I think that to me is one of the shifts that has to occur if we're going to go beyond just a playing at the edges of how we can use technology to support it. And that obviously links with the whole chronic disease management, the longitudinal need to manage and work with people. It's not episodic individual pieces of care. It's how do we wrap that technology around individuals longitudinally and in a supportive way to improve their long-term outcomes.
Which has a heavy data element to it, a bulk data element, a connectivity of different points of data in a person's journey, which I do want to come to as well. And certainly, and to your point, we have a lot of healthcare practitioners in our business and fantastic at what they do and really what digital technologies are enabling us to do and for them to deliver is a more personalised care, and they love having those tools available to be able to do their jobs better.
Absolutely. And I think many of the disruptive industries at the moment. I mean disruptive not in a negative way. I mean the disruptors that are in here, the difference as well is that they're actually becoming healthcare organizations themselves, where perhaps traditionally technology companies sold into the healthcare business. But you're increasingly seeing groups like Best Buy in the US, and there's many examples you can refer to where they're employing health professionals and doing it in a different way, because you're a digitally native business, so you know how to do it. You build it up from the bottom. Whereas it's challenging for traditional health services that don't have a digital model to actually become digital. It's kind of logical when you think about it like that. But I think that is one of the fundamental challenges, why it's easier for business to come in and be digital from the start rather than trying to layer it in as we go forward.
And it's been seen in multiple industries, product verticals and industries over the last 20, 30 years in particular, that really the incumbents really do struggle with that inertia and really to disrupt themselves. And that's what's led, of course, to so many startups being so successful.
The Clay Christensen disruptive model. It goes back to ice makers. There wasn't a single ice maker that moved into refrigeration. It's that kind of challenge that it's really hard for businesses that have been disrupted to do that. But healthcare, we can't just get rid of all the old and go with the new. And I think this is some of the dance we've got at the moment of how do we integrate the new businesses that are digitally native in with existing services, and how do we manage that program?
Absolutely. Now, I wanted to ask you about Indigenous health in the Northern Territory.
Sure.
That's right. So you spoke before about assistance in Redfern or Broken Hill. I know you do a lot of work in the far northern communities as well, and starting to get more involved in that world. I'd love to get your thoughts on what's happening there and how we can best deliver using digital technologies care that's really personalised in that part of the country.
Absolutely. I mean, one of the fundamental things I'd say first up is that it doesn't matter whether you're in Tiwi Island or in Blacktown or wherever. I mean, equity has to be on the table. It has to be, and I think technology has to not just match existing service, particularly for marginalised and disadvantaged groups. It has to make it better. And I think we've got to design our systems fundamentally to improve the people that don't currently access care. And a fundamental issue I have is that I think a lot of digital technologies, both in public and private, focus on people that basically don't need that care. They're people like us, that are relatively well off, can manage our own healthcare, health literate, and we can't just design systems for those kind of people. We need to design for people that have, for whatever reason, harder ways of accessing care. So, I work in Western Sydney a lot with a cardiologist called Clara Chow, is very community focused. So in that instance, we're working with, diverse cultural, economic background kind of groups of people, different education levels and so on. Work I'm leading in Northern Territory is we're looking at how can you support comprehensive primary healthcare in remote Indigenous communities. There's been a lot of failed attempts to use technology in that environment. I think there's actually a fundamental misunderstanding or lack of understanding of what Indigenous communities and Aboriginal and Torres Strait Islander people actually want from technology and how can you use that. I think we're tending to focus inevitably on urgent primary care, I could say, rather than preventative longitudinal primary care. And so we're really, a lot of that project, which is in partnership with the Northern Territory Government and the Commonwealth, as well as a number of other agencies, is really just to fundamentally understand how we work with communities, what they want, how do you move technologies into those communities, how do you create a model, how do you fit that within an Aboriginal model of care, and what are the key components of that. So it's a project I'm very passionate about and very excited about, because I think you have to have that equity at the heart of what you do.
Absolutely. Thank you. And I wanted to come back to the data piece as well. I know you're involved in the sort of practice analytics program, and that's in some respects related to this element of healthcare. Love to hear more about that.
Sure. I think as well, if we've got a moment, I think the other data piece which we draw on momentarily is this predictive analytics piece. Right? I think as well, before I go to the practice analytics piece, is that, and obviously we have increasingly large data sets being held by other organisations within and outside of healthcare.
Google,
everybody.
Amazon,
we all do it, right? We all click yes to our mobile phone when we log into things. And so there's these massive data sets. And I work with some American companies that actually work a lot with Medicaid data sets in the US, which are really comprehensive. They're billing data, but they're very comprehensive data sets, mental health, primary, acute care, and so on. And they're starting now to reach into those data sets to identify people at risk of whatever, fairly low key initially around who hasn't had vaccinations, who hasn't been screened, and so on, but increasingly sophisticated analytics on that to reach out.
Is that unique to the US, given their system?
I think, no, it's not unique, but it's the biggest scale I've seen. So the company we were working with sends about 1.5 million messages a day out to the Medicaid populations they work with, nudging, reminding, changing the way people do care. And then they've got a constant feedback cycle going on about how they can use that information and how people change their behavior, because they can nudge somebody and then track it and see, oh, that worked for that person, which might be a middle-aged woman living in a rural location in Kansas, right? And so that means how you message to them. So I think there's a massive opportunity there. And I think something we have to be very careful with as we move forward with this technology is we use that carefully so we don't lock the data down so we can't use it. If we put increasing restrictions on access, then we lock down the ability to do that. And I think, it's vital that we build that in. And obviously, as we have more in the hand AI, like ChatGPT and others, where it's really going into the consumer and the clinician's hand, we have to be able to work with that data and information.
How's that balanced against the obvious question of privacy, security? If there's a consolidated set of data in one area, does that make it more vulnerable?
It's a real problem, and I lecture this to medical students, and I often kind of set scenarios about what are you comfortable with. Are you comfortable with having AI look at your Medicaid data sets to identify when you maybe haven't done something? Maybe you're a 58-year-old man like me that might not have been screened, had a blood pressure check recently. We can tell that now. I mean, somebody could reach out to me and say, Tim, you haven't had a heart health check in the last 5 years, right? And I've got congenital heart disease. I mean, I have had one, but it's that kind of thing. But how comfortably with this? And for me, it's the journey we've got to take together. Right? The challenges we had, I think, with My Health Record implementation, many of us remember, is that I don't think we took the community with us in this. So we have to be able to work with people to say, how comfortable are you with this? And it has to be about benefit. If we're just going fishing for data, then people get suspicious, rightly. But if we clearly define why we're doing this and how we're going forward and show the benefits of it, then I think we'll be better off.
Great. Now, I wanted to move to some questions that I often ask at the end of this interview, and they're a bit of a rapid fire. Great to get your thoughts. So when it comes to taking active control of your well-being, which generation does it better? Boomers, X, Y, or Z?
It's a really interesting question. I mean, boomers are obviously in that phase now that they're high users of health services, and there's a remarkable number of people that actually in that boomer generation really do use technology well. So I think they're doing that quite well, but it's probably too late. I'm not being pessimistic. My brother's a boomer, but really, if you haven't sorted it out by the time you're a boomer, you're really managing chronic disease by that point. Why? Which is me, probably got some time left in there. We're very technologically literate as a generation, perhaps better than our boomers, and it's probably time to catch some of those chronic diseases. I think some of the younger generations, they're digitally native, but digitally native doesn't mean you look after yourself. Right? There's this fundamental problem. Everybody assumes because our doctors now going out and our nurses and allied health professionals are digitally native that they'll just know how to do telehealth, they'll know how to use technology in healthcare.
Problem set?
Yeah, they just don't. It's just so. I think that those generations are very well placed to look after themselves, but they need to be helped, and we need to make sure that their technology use supports health and wellness. And I think that's a challenge. So just because you can use an iPhone better than your father or your mother doesn't mean that you're going to use it for your own health benefit.
And what about the next generation, or the current Generation Z, born 2010 onwards, the kids today? What are they going to teach us about well-being and specifically about technology when it comes to our health and well-being?
Look, I think there's some really interesting things. I think some of the younger generations definitely are more focused on for purpose, both their employment and their lives and so on. And I think they've come through the COVID, and I think many of those people are reflecting on what they do with their lives and how they manage that. And I think they are taking more time to reflect on that. I think there's much, much greater awareness of mental health issues. I know in my own family, there's much more open discussions about people that might be at school that have mental health and other issues, and it's much more open and encompassing. So I think those generations are well placed to maybe not have some of the stigma associated with some of the major chronic diseases we have, and actually move forward as a generation to improve that. So I'm actually really optimistic.
Fantastic. And which technologies do you think are going to be most beneficial to wellbeing? We've touched on a number over this chat. AI, for example, is one that potentially could be a double-edged sword, and on the downside, which one could be potentially detrimental?
Look, again, maybe I wouldn't pick a technology. To me, it's the constellation of technologies we wrap around people, because the only thing you can say about technology is going to change. I think AI is obviously going to be important, but for me, it's how we build a constellation of technologies around each person, so and have that technology move in as people become sick or needing care, and move out as they don't. And how do we manage that longitudinally over somebody's life without being Big Brother, right? And how do we do that in a safe and effective way? And undoubtedly AI, lifelong AI is going to wrap around that, as we go forward. But to me, it's that constellation and that arrangement of technologies that can deliver maintenance and healthcare in a personalised way.
Thank you. Last question. What's your favourite futurist prediction, if you have one, in the world of healthcare?
Look, I think it's the kind of, to me, it's the cradle to grave use of information and technologies that I mentioned longitudinally over your lifespan. So maybe in 5 to 10 years' time, we will have a disrupted digital health service where it will just be routine that we have technologies wrapped around us. And it'll be routine that our data is used for our benefit. To support our care and our interaction with the health system, but personalised to who we are, and ensuring that we maintain equity for our most disadvantaged.
Well, on that note, thank you, Professor Tim Shaw, for joining us here today on Active Care Matters. Thank you to our audience as well. We'll see you next time.
So as most of us know, illness can happen at any time, and rarely any of us are prepared. So it can happen at 3 a.m, can happen when you're at work and even on holiday, or even in a different country. And something that happened to a person who we'll call Joy. So Joy was travelling from Australia to Vietnam and contacted Sonda, highly distressed, a little unsure of how to manage her situation in Vietnam. She made contact using the chat function on the Sonda app. So here you can call by phone, you can call via chat. So she chose that, spoke to one of our support coordinators, so real humans, not bots, which is one of the big advantages of Sonda's digital platform. It has the ability to easily connect wherever in the world you are, whatever time of the day, because we are 24/7, 365 days of the year. This meant that Joy was able to access support regardless of the time difference or a geographic location. The Sonda nurse was able to quickly assess that Joy's distress was actually the result of an underlying serious mental health condition. She also disclosed to the nurse that she was having suicidal thoughts. So Sonda's priority, as I said, is all about safety, and that's what we needed to ascertain. So harm to self, harm to others. Joy was strongly encouraged to attend the hospital for a more comprehensive assessment with a medical health specialist. One thing that we do need to look at when we do send people to hospital is there some sort of organic reason. So they do need blood tests, they do need a medical workup as well before they have a mental health assessment. So a taxi was also arranged for Joy to take it to the nearest hospital. And whilst waiting for the taxi, the nurse stayed connected with Joy for a period of time until they arrived and provided just supportive communication, reassurance, and making sure that she was safe. She didn't have any supports with her, Joy, so she was travelling alone. The next day, a follow-up call was made by the nurse just to confirm that she was safe, and also to confirm that did she need anything else from us. Joy had told us that she had immediately gone into hospital, had a full assessment that was conducted and treatment provided to help manage Joy's mental health. And soon after, she was discharged and back to a holiday. Don't forget to join us next time on Active Care Matters.